and welcome to the City Club's second Healthcare Technology Forum, The Cost of New Healthcare Technology, Who Pays and Who Wins. In the last 5 years, the technological advances in healthcare, especially in the areas of diagnosis and treatment, have been incredible. But what are the costs of new healthcare technology, and how are they paid for? What about competition and market demand for technology? Who decides if the cost of expensive treatments are justified? Today we have an outstanding panel of experts who will address these questions and more on this controversial topic of healthcare technology and costs. The City Club of Portland presents this open forum for informational purposes only. The views expressed or implied by the members and speakers are not necessarily those of the City Club or its members. The City Club does not take positions on public matters without submitting questions to a rigorous research process. Our first speaker will be Chad Cheriel. Chad Cheriel is the Director of the Office of Health Policy in Oregon. The office is involved in healthcare planning, data collection and analysis, and making policy recommendations to the governor and the legislature. The office is scheduled to be merged with the Office of the Health Plan Administrator in the near future. The office has had a number of charges over the years, some very broad-based and other very narrow, such as regulating the supply of health cost, medical technologies, and services in the state. The office was instrumental in creating the Health Resources Commission, whose primary mission was to develop a rational process for diffusing medical technology in the state. Before joining the office, Chad was the Health Policy Care Administration Program faculty at the Oregon State University. Chad and his undergraduate training in microbiology and medical technology, and has received his PhD in political science and public policy from the University of Oregon. He is well known in healthcare circles as an extremely knowledgeable advocate for quality healthcare in Oregon. He will examine many of the community healthcare issues such as regulation, community sharing of resources, duplicative services, and end-of-life decisions. Our second speaker will be Dr. David Tilford, a pediatric oncologist with Northwest Kaiser Permanente and clinical associate professor at the Department of Pediatrics at Oregon Health Sciences University. Dr. Tilford is also the Assistant Medical Director of the Kaiser Permanente Northwest region, where he has served on committees such as the Regional Technologies Committee, the Transplant Committee, the Interregional New Technologies Committee, Regional Quality Council, Regional Appeals Committee, and Health Plan Review Committee. Dr. Tilford will examine the effectiveness and cost-benefit of technology, experimental technology, and community standards. Our third speaker will be Barney Spate, Assistant to the President, Vice President of Corporate Development for Blue Cross and Blue Shield of Oregon, and its managed care affiliate, HMO Oregon. Mr. Spate is responsible for the areas of government relations, communications, research, and analysis. Blue Cross and its affiliates provide health care benefits to more than 1 million subscribers in Oregon with annual revenues of $1.2 billion. Mr. Spate has also served in a variety of roles at the Oregon Medical Association, the Oregon Hospital Association, and Good Samaritan Hospital. He is a member of the Oregon Health Resources Commission, on the board of the Foundation for Medical Excellence and Oregon Health Decisions, and chair of the Small Employer Carrier Advisory Committee of the Oregon Department of Insurance and Finance. Mr. Spate will discuss cost technology issues in relation to insurance, managed care, and capitation. Our final speaker today is Dr. Patrick Dunn, Assistant Professor of General Medicine at the Oregon Health Sciences University and Assistant Chief of Medicine, Legacy Portland Hospitals. He is a reviewer for the Certificate Program in Healthcare Ethics at the University of Washington and Assistant Director for the Center for Ethics at Oregon's Health Sciences University. In addition, Dr. Dunn is on the faculty of the Northwest Center for Physician-Patient Communication and coordinator for the Task Force to Improve the Care of Terminally Ill Oregonians. His research topics include health services research, medical decisions analysis, cost-effective analysis, and healthcare ethics. Dr. Dunn will discuss ethics within the new healthcare environment in relation to the patient-physician relationship as it impacts technology and cost. As you can see, this is an impressive group of healthcare experts, and I know we are all waiting to hear their presentations. Each panelist will speak for 15 to 20 minutes. After all 4 speakers have presented, we will entertain questions from the floor. Now, please help me in welcoming our first speaker, Chad Cheriel.
Good afternoon. I'm not sure if I'm exactly going to cover all the areas that Sandy mentioned, but let me help frame some of the issues in a fairly fast evolving, changing environment of healthcare. I would like to start by stating what I would consider a series of facts that kind of help frame the health policy environment and the nature of changes that are likely to take place. Many of the public arenas where I have given presentation, I have tried to articulate the fact that healthcare is unlike most other services and commodities. Healthcare is a unique product, and therefore it operates under a unique set of systems, relationships, and so forth. The first point is consumers are insulated from consumption and purchasing decisions. This is a fact that everybody knows. 84% or more of the population is insured, and usually the purchasing is done by employers or government, Medicare, Medicaid, other public employees, by their government as the employer. This creates a number of problems in that any sort of policy changes you could drive to impose burdens, particularly economic burdens or economic incentives on the individual consumer, may only have limited impact, and I'll come back to that later. The corollary to the first one is that clearly physicians in general act as agents for the consumption decisions, particularly in the sector of medical care. I have seen studies which shows that about 80% of all consumption decisions, meaning what is to be consumed, how much, where, and when, are primarily decisions made by physicians and not by consumers. Clearly, consumers as yet cannot admit themselves to hospitals. They cannot order surgeries, surgical procedures. They cannot write prescriptions. So it relates to the first fact in that as long as the decision is left up to a different agent, the impact consumers can have on the healthcare system is limited. Most medical care consumptions take place at the tail end of a person's life. There have been studies that shows anywhere from 60 to 70% of total expenditure, total consumption by an individual really happens towards death. Studies have been done on Medicare patients. That's the one that I remember the most. There have been series of other follow-up studies. That also has an impact indirectly on what sort of interventions you can impose on consumer behavior and his or her ability to change the consumption patterns. Demand for healthcare is generally inelastic, very clear distinction from most other services and goods, in that price may not be the primary determinant of what, how much, when a person is going to consume healthcare. you cannot necessarily price shop, even though on the insurance side, a person may be able to shop around for the best insurance package, but when it comes to the service, consumption, and delivery side, most people are not in a situation where they could price shop, particularly on the high end of the price schedule. Demand for medical services in the aggregate is relatively fixed, meaning that the relationship you see in all the other sectors of economy, where if you could produce a lot of a particular commodity or service, you have the ability to reduce the overall cost, and therefore a dynamics takes place where it feeds on itself, where you could produce more and therefore the price lowers. More people purchase the commodity or goods or service, and therefore it takes on its own economic results. Whereas in healthcare, if you take a population as a whole, there's only a fixed demand. And in a simple way of looking at it is there are only so many heart surgeries you could do, there's only so many hospitalization you could carry out, there's a fixed demand in a sense for the number of physician visits, etc. Within healthcare. Consumption of greater quantities of goods and services in healthcare may not lead to increased satisfaction. In fact, people have written about the concept of iatrogenic diseases. In other words, overconsumption could lead to negative consequences and dissatisfaction and so forth. Over the last 10-20 years, people have written quite a bit about the fact that technologies are the real engine that's driving the cost equation in healthcare. There's quite a bit of literature on it. The estimates have ranged anywhere from 50 to 70% as the percentage that you could account relating to technology. And of course, what drives technology is the reimbursement scheme that we have had in place up until very recently, which is drastically changing, and that creates new opportunities and new problems. We are clearly at a critical juncture in terms of both delivery and reimbursement. Many of us thought even financing has the potential to change, but that has not changed. But in terms of delivery, which is driven by the managed care environment, it's hard to keep track of the penetration rate. I've heard ratios anywhere from 70 to 90% of the population is or very soon will be under some sort of managed care system. And within managed care, the reimbursement system will have significant impact on both technology consumption and the patterns of behavior, particularly on the part of the suppliers of technology. Let me just quickly review with you some of the incentives that were very prevalent and incentives that drove the system in the past. I'm saying that in the past because of changes that are taking place. We do not have the adequate measurement tools right now to critically account for that, but it's fair to say that things are going to change in terms of consumption. In economics, quantity, price, cost, and profits are related. In any other sector outside of healthcare, one could reasonably argue that if you could continue to increase the demand and therefore increase the production of a particular good or service, you could, generally speaking, lower the unit cost. As you lower the unit cost, you could attract more population into the market, and therefore you have a new dynamics. And as you increase the consumption and the market share, the profit rates invariably increase with it. And so you have a situation where in most areas you could continue to expand demand, whereas in healthcare, as I said earlier, that may be of questionable value. In fact, it could have negative consequences. And I have, over the years, focused on one technology, one of my favorites, because as a regulator, I have had to make decisions in relation to that. about its supply in Oregon. These are the MRIs. The economics of MRIs were very clear, particularly to the suppliers. Within a very short time after it became available, the price of units started to drop, and the suppliers, the service providers realized, given the absence of competition, price competition in the marketplace, you could increase the supply of services within a population base, and therefore substantially increase the profitability. It's very simple. A machine costs about $1 million, and on the average, a machine could generate about 4,000 scans, although now some of them could operate at about 5,000. And each of the scans costs anywhere from $750 to $1,000, and you could do simple mathematics, multiply those numbers, and you realize you can pay for the machine the first year and realize profitability that far exceeded the original cost of the machine. And therefore we saw a tremendous proliferation across Portland and throughout Oregon, and actually across the country. This is very similar to what happened in hospital beds, in surgeries and so forth. In the area of surgery, during the 70s and 80s, there were a lot of studies that attempted to limit the supply, put constraints on through variety of mechanisms, including one of the most popular one that was around was the second surgical opinion that, by the way, turned out there's conflicting results on that. Some arguing it has done some good, others arguing all it did was added to the total cost. Most recently, Milliman and Roberts, a '92 study, pointed out that there's about 15% inefficiency in ambulatory care, about 25% waste in admission rates to the hospital, and when that's translated into hospital days, it's about 53% across the country. This again in an older reimbursement system where there were no limits on the total resources that could be consumed by healthcare. It was easy to drive the system regardless of the efficacy, the well-being, satisfaction, and benefits consumers derived from it. The system was driven primarily by technologies, and there were people benefiting from it. There were a couple of other phenomena, practice variation. There have been a lot of studies, famous one, actually a series of them by a professor, John Wenberg, both within a limited area and across countries, across the country and across international boundaries. There's all kinds of studies of variation. And these are generally considered supplier-induced demand. In other words, we like to think there's some sort of norm, the optimal levels of practice that communities ought to know, except in some cases the variations were very, very significant, many times the rate of what one might consider optimal, or from the low to the high. And these range across all the spheres, heart procedures. I used to use the sample of a study that was done in pacemakers, where a group of researchers went back and looked at the experience and realized close to 50% of the pacemaker implants were either unwarranted or of questionable value. Ultrasound, variety of other radiologic procedures. Plenty of studies that shows under an old scheme, reimbursement scheme, there was significant supplier-induced demand. Interestingly, because of a whole set of reasons I won't go into, the delivery and reimbursement system is changing, and Portland and Oregon is at the leading edge. As I indicated, 70 to 90% of the population is or will be under some sort of managed care. This means the incentives are going to change drastically. Whereas in the old days, you could expect to increase the market for goods, for surgeries, for MRIs, for CAT scanners and so forth under the new system, because the revenue is fixed. any increases in volume of procedures, admissions, ambulatory care, whatever, is going to be an item that takes away from the revenue. In other words, it becomes a cost item rather than a potential profit item, and therefore the incentives are going to change, and therefore my belief is that the practice variations are going to reduce, is going to decline. You're going to see more convergence towards some sort of norm, although we don't know what those norms are. The technology itself, as opposed to the behavior patterns of the past, we're going to see less diffusion with potential costs that I'll briefly mention in a moment. Under the new system, any new technology, such as PET scanners or some modernized version of CAT scanners or heart procedure technologies and so forth, I do not believe any plans, suppliers are going to rush out and try to accumulate those, because there are no economic incentives that will drive them to that. There will be much more careful evaluation of the efficacy of new technology. I'm not sure exactly who's going to do that, but that will become a much greater concern before adopting new technologies. And this is technology in its broadest sense, whether it's the gadgets or medicine, pharmaceuticals, or procedures. Practice variations, as I said, the variations are going to be much narrower, primarily again because the change economic incentives, because of the fixed price of the new arrangements, plans, insurance companies, purchasers are going to become much more active in making sure that the practice patterns follow some sort of norm. And again, norms will be determined either by the professionals groups or by some public-private partnership. Many procedures and practices that were previously considered of marginal value, which, by the way, medical journals are full of research findings where they have been excessively used in some cases. Those of marginal value will start to diminish, and I believe eventually will disappear under the fixed revenue scheme. Now, what does this mean in terms of cost of technology, its diffusion, and so forth? There is a possible threat, a caution. As we change the economic equation from that of more profits to a fixed revenue in which plans and providers and suppliers will have to operate, what is to prevent the system from going too far in the opposite direction? In that in the past we had an overabundance, overutilization, over-scanning, over-procedure, over-medication. Now, because those become cost, volume become cost, there may be a tendency, or at least there's a potential tendency, to try to minimize that to the maximum extent, except consumers and purchasers may not know where that line should be. And that would be a new policy public challenge. And that obviously could also have impact on quality and satisfaction. Here again, the amount of information consumers and purchasers have been limited in the past, although some progress is being made in making that information more broadly available. The question is, would public have adequate knowledge and information to make those critical judgments as to whether or not we've gone too far in the opposite direction? What is the likely consequence on technology innovation? Keep in mind at least I've read here and there, that some of the most expensive technologies, like MRIs and CAT scanners and so forth, that were major money makers for healthcare industry, really did not get started within medicine. They got initiated outside of medicine, and they later found utility, usefulness for medicine, and therefore there was kind of a migration. And at least some of the research have shown, in some cases when it comes to pharmaceuticals, for example, not all innovations were genuine innovations. Sometimes these are simply marketing strategies rather than pure innovations. Anyway, as resources become constrained, they may be a dampening effect on technology, and in an indirect way, diffusion of technology. Let me back up and talk about MRIs. As MRIs became more prevalent, the unit cost did go down. If plants become much more careful in accepting new technologies because they want to be sure that these provide some sort of value to their clients, then the opportunity for suppliers to continue to supply more and therefore reduce unit cost will be limited, and therefore there's a potential that you have, even when there are useful technologies, the time it's going to take to diffuse across broad areas may be much greater, and therefore diffusion could have potential negative consequences in terms of providing satisfaction for the plants and the consumers. When managed care was becoming popular, I remember going before a legislative committee and talking a great deal about how wonderful this is. It took a number of years before, in a sense, caught on and became the reality, particularly in Portland, Oregon, and a number of other communities. Now I think policymakers and public ought to be working with the plants in making sure adequate levels of information knowledge is available to the purchasers and consumers, in that the availability of services, and particularly those technology-driven services, costly technology-driven services, would not be reduced or diminished in a new scheme where you do not have an open revenue stream to participants in the system. I'll stop at that. Go on, thanks.
Thank you, Chad. And our next speaker will be Dr. David Tilford.
Hi. My segment of the discussion this afternoon is titled Efficacy of Technology in Relationship to Costs. And just let me warn you, this is probably going to be a pretty low-tech discussion, so that may be an overstatement. New technology seems to get a lot of bad press. Is new technology good? And I would say, of course it's good. What makes new technology good? Well, it's good when it creates better healthcare outcomes. As a pediatric oncologist who's been involved with the care of children with cancer for 25 years, when I began my career, probably less than 10% of the children were surviving their disease. Now in the mid-1990s, greater than 70% of children are surviving their disease. This is the result of new technology. Is there any cost which would make effective new technology unacceptable? And I'm going to leave that discussion to our two final people to answer that question. So when we talk about the cost of technology, how is it that we're actually coming up with $1 for something? The most obvious thing is that you do something with something technical, it costs you something, and you get some benefit. That's just a direct costing analysis. On the other hand, usually there may be more than one technology available to you. You could do this, you could do that. They each have their cost, they each have their benefits, and you do some relative cost analysis that it makes more sense to do this than this because of your ultimate benefit. It may cost a little more, but the increased benefit seems to be worth that. And then there's a bit more sophisticated looking at costs, because when physicians or health plans look at costs, they're almost always just looking at what it costs the healthcare system directly. The cost of doing the MRI, etc. But in fact, there are so many costs that you could take into consideration. What's the cost of a person having to be in a hospital and not at work? What's the cost of a mother needing to be somewhere to get health care versus being available to take care of her children? What's the cost to society at large for certain kind of problems? When you get into these kind of assessments, you usually come up with the need to get much more sophisticated in your cost analysis, and you usually come up with some kind of incremental cost to generate some kind of either life year or, more typically, some kind of adjusted quality life year. And this is much more sophisticated and typically has to take into consideration costs that go beyond just the medical care environment itself. An example that one might consider that is in a fairly controversial area is that of using autologous bone marrow transplant for the treatment of advanced breast cancer. One way about looking at this would just simply say, well, what's it cost to do an autologous bone marrow transplant? And you could say, well, it costs $100,000 to do an autologous bone marrow transplant, and the benefit is that the woman with breast cancer may survive for a longer period of time. Then the issue is relative cost. What's the difference between going down the road of autologous bone marrow transplant, or would it make just as much sense to do classic aggressive chemotherapy? And then you find that if the classic chemotherapy is considerably less expensive, and the differential between the benefit is that 5% of women may have a better outcome with one than the other, then you're going to have to rate that differential in improved benefit over a significant differential in cost. And ultimately, if you're really trying to understand it, you really need to understand the full impact of doing that autologous bone marrow transplant on a whole population of women who have advanced breast cancer. How many dollars are you going to spend to have one adjusted quality life year improvement? Women who get autologous breast cancer are more likely to die sooner, simply because of the complications of the procedure. On the other hand, there may be very few women that are ever going to ultimately survive advanced breast cancer without the potential for an autologous bone marrow transplant. Very, very complex formula for which the individual physician, individual patient, individual health plan is not it's seeing the whole picture all at one time. There are various attributes that play out across the whole range of categories of new technology. I'd like to discuss just a few buckets of technology. In the surgical arena, we've seen a significant advancement in some of the equipment that's available for surgical procedures. All the different laser equipment, all the different endoscopes that allow us access to parts of the body that we're not sure we want anyone to have access to. And how does that play out? Well, these lasers are very expensive equipment. It costs a lot to have one in the operating suite. Also, many of the endoscopic procedures, taking out a gallbladder with an endoscope, actually takes 2 to 3 times as much operating time as the good old cut and tear method of getting right in there with your hands. So what is the cost issue here? Well, actually, you have to balance the cost of OR time against the cost of extra hospital days if you do it the old way. And that's not even considering the benefit the patient might feel of not being in the hospital, getting back to work sooner, and all those other expenses. Imaging. Imaging always gets looked at here. Started off with CT scanning, moved up to MRI, and now the infamous PET scanners out there. And in fact, what we're seeing nowadays is a very interesting interaction between the imaging equipment and surgical procedures. We now have many stereotactic surgeries in which the patient has imaging done right at the time of surgery so that the equipment and everything can be guided to exactly the right place in the body. Again, balancing the cost of the equipment against other factors. And as Chad mentioned, this is where volume can play a big role in the overall cost. If you can drive the volume of your procedures up, then the actual cost per unit for this new technology can be driven down. The other thing about imaging is the problem of a replacement technology versus an additional technology. MRI is to replace CT. Well, no neurosurgeon worth their salt is going to go to the OR without both the CT and the MRI. So you haven't really saved anything there. The PET scanning brings up all the same issues. Yes, PET scanning will tell us some things that CT and MRI will not. Would anyone be willing to use PET scanning to replace the other technologies? Probably not. And the bottom line is, does PET scanning really tell us anything that ultimately is going to change the outcome of that patient and their disease? And there's real questions about that. Within the therapy arena, there's transplants, which has been up in the forefront as far as technology for quite some time. The transplants in the arena of solid organs like lung, kidney, heart seem to be pretty straightforward in that you have a failing organ and you replace it, and the patients generally do exceedingly well. Bone marrow transplant has been the one where there's been much more controversy. For the most part, you're not doing the bone marrow to replace a failed organ. You're doing the bone marrow as a rescue in order to do high-dose chemotherapy to cure a cancer. The problem is it's not always proven beforehand that the high-dose chemotherapy is going to be any more effective than aggressive standard chemotherapy. Other arenas include the advancements in radiation, cryotherapy, lithotripsy. And again, we get the interaction between the therapies and the imaging studies. And now we have stereotactic radiosurgery or gamma knives. In the sense, again, you hook up these imaging machines with your therapeutic modality that's non-surgical, and you're able to focus it down. And finally, there's the whole area of drugs. And this is a very interesting and difficult area. Those of immune-type drugs, cancer drugs, metabolic drugs, drugs for MS, drugs for Alzheimer's. A couple things come up here of interest as far as the cost issue, and that is, what do you do when a drug is the only option to offer a patient versus nothing? And you put that up against, but it doesn't do very much for most people. And then you add on top of that, it's very expensive. Now, who's supposed to make the judgment call about who should get that drug? This certainly holds up for both the drugs currently available for multiple sclerosis and Alzheimer's. These are very, very frightening, overwhelming conditions, but the drugs, in fact, in double-blind studies, it's very difficult to show that they change much. You get anecdotal evidence on uncontrolled studies that some patients get better. And now there's huge demand, typically fueled through the drug company with patient support group to start going for the health plans and physicians to cover these drugs. Another is an interesting pricing strategy. An example here is a new drug, or not a few years old, in oncology, a drug that gets called granulocyte colony stimulating factor. This drug is meant to stimulate the bone marrow to grow back faster after chemotherapy. If you can do this, you then typically will have fewer infections. You get infections, you're in the hospital. So the way the drug company decided what the cost of the GCSF should be is, it should be a little less than a cost of a hospital stay. It doesn't have much to do with how much does it cost to make the drug. It's, if I make it so it's less expensive than the alternative, people will buy it. So This is the issue of what does something cost versus what is something priced at. And that's a whole other issue in the marketplace. And now that I've told you about all those new technologies that are right out there and the patients see, they feel, this is what everybody thinks about, my own perspective is the new technology in medical care that is currently needs to and will be consuming the vast amount of dollars is our information systems. We are moving into a new era of needing to manage the information about patients. We need to be sure that every clinician has access to the complete medical data set when the patient presents everywhere and anywhere. We need to have reminder systems and outreach systems that make sure that all the people get all of their preventive care. We need to be able to get in front of the physicians instantaneously as it relates to an individual patient, best practices and guidelines. And we need to be able to know when we've done something that has improved care. Getting back to, if it doesn't give you a better outcome, it's probably not a good technology, whether it's a new technology or whether it's an old technology. And this is where information systems are going to be the backbone of our being able to generate true outcomes data. From my perspective, information systems, which truly is a new technology for medicine to use, will be the glue that holds medical care systems together. Now, saying this and the cost, what can physicians, healthcare systems, a community do to try to control the costs of truly good new technology? And I think this community has many examples of how to collaborate in the use of new technology amongst competitors. One very good example is the regional lithotripsy service in this city. A lithotripser is a very expensive machine that basically is an ultrasound machine that puts in real high energy ultrasounds that can break up kidney stones and then allow the patient to pass those kidney stones without internal intervention. Very expensive. Kaiser Permanente, along with several other hospitals and health systems in the Portland metro area, went together to form the regional lithotripsy service, having a single facility currently housed at Legacy Emmanuel. And all of the groups with their urologists jointly manage this program. It has become one of the most high-performing, high-quality programs in the country, and probably creates the least cost per unit of service of any other lithotripsy service in the United States. Transplant programs. A couple years ago, it looked like we were having transplant wars, and seems to settle down a bit. Transplants are going to be volume dependent on cost effectiveness and probably quality. It is important that we concentrate our heart, liver, kidney transplant programs at institutions where multiple healthcare systems have access to those. OHSU has been the center of those programs that Kaiser Permanente has predominantly used. One recent collaboration that just came about that doesn't sound terribly high-tech, but in fact has very significant technology, is the CARES Northwest program that just opened. This is a collaboration of Legacy Children's Hospital, Kaiser Permanente, and Dornbecker Children's Hospital to put a child abuse team together where all children in the city can come get good, high-quality assessments using the latest colposcopes. These are magnifying instruments that allow you to look at genitalia, etc., of children at quite a distance so that they are much more comfortable during the exam. And this is an extremely high-quality program that groups come together to have. There are many other examples in which we believe at Kaiser Permanente that we've reached out and joined with the community in a center of excellence. I was going to talk very briefly about some of the driving forces about the utilization of technology, which I'm sure, again, the next speakers will comment about. But there really are quite different incentives for what drives a given technology to be used. There's the whole side on those that provide the actual technology. For physicians, it starts with those in the developmental stage that are actually doing the research around a technology. They become very avid champions of that technology. And that can play a significant role, especially if you live in a community where that champion exists. it can almost make it very difficult for you to continue your care in that community without offering that. Once it becomes a little more mainstream, physicians are going to want to be up to date, able to do technology. It's good, it's fun, it's modern. And for many referral physicians, this may be the basis for which they actually will get referrals if they can show they've got the newest technology to offer people. There's obviously aspects around the clinics and hospitals. In the past, these have been profit centers, as Chad points out. When you go from a free for service, that never happened, fee for service world to a more prepaid managed care world, everything moves from profit center to cost center. It's just the automatic about whether you're going to get paid after you do it or whether you're paid before to cover everything. For hospitals, it's also a matter of prestige and setting up centers of excellence that will attract patients that will use bed days. Bed days are dropping dramatically. It is still important that hospitals who get paid by health plans have their beds used efficiently. And of course, we have our manufacturers out there who are making a product. They want to sell it. Equipment, drugs. They're not doing it just the old way anymore. Open Time magazine, and you'll typically see 5 to 6 drug ads telling you to go to your doctor to tell them that this high blood pressure medicine is exactly what you need. This is the right antihistamine for you, and nothing else will do. The customer side obviously is a big driver of utilization of new technology. Patients, they want the best care. They know they need an MRI before you can possibly help them with their knee. There is nothing you can do until they have the MRI. And there's last chance care. How could you possibly not give me a bone marrow transplant? It's the only chance I have. You have nothing else. It may not do anything, but it's my last chance. Health plans. I would suggest on the positive side that the most driving force for health plans is for cost-effective care. They want the total amount of health care to be down, and using technology at the appropriate level at the appropriate time ultimately should drive down healthcare costs. And ultimately, there's the payor, whether that's the individual, whether it's the government, or whether that is a health plan. And what we're being told exceedingly loud and exceedingly clearly is, we want high quality, and you're going to lower your healthcare costs. And figure out what to do with technology. Thank you.
Our next speaker will be Mr. Barney Spade.
I'm glad I'm going third and not fourth, because Dr. Dunn gets to answer all the questions and pass them to the end. I think you've probably gotten the sense that perhaps this panel is less going to answer questions than probably pose larger questions that we can all discuss when we get to questions and answers. And I guess what I'd like to do in just a few minutes is add a few thoughts about how the world is changing, and Chad has touched upon that, and so has Dr. Tilford. From the classic third-party payer point of view of Blue Cross Blue Shield, say 10 years ago, we basically paid for benefits under a contract, and many of the issues of new technology fell into a medical, legal area of looking at what's experimental and investigational and what's not, and then what's medically necessary if a technology is no longer experimental or investigational. What's medically appropriate, what's medically necessary under the contract. And our role as a third-party payer was really to police the activity of the delivery system, which was fairly active and we were fairly passive, but trying to police that as medical care and medical technology evolved very quickly. And I think it's safe to characterize at least the last 50 years, so the real emphasis has been on access and quality, with technology driving a lot of the both improvements and the cost of care, as has been indicated. Our attempts, most third-party payer attempts in that old role, were to stay abreast of technology as it was under research and understand its proposed clinical application, to stay abreast of technology as it was beginning to be introduced, to understand even more precisely the clinical indications in which the best outcomes could occur, and then to really test at the local level, and in the case of Oregon, statewide, what's the community standard of physicians, primary care physicians, specialists that are involved in the technology, other specialists who may be involved tangentially in the technology, to really get to a medical legal term called what's the community standard. Because the community standard ultimately in any kind of insurance dispute is, were we paying the bill appropriately or not appropriately relative to our contract terms, medical necessity. And medical necessity really comes down to what are the standards of physicians relative to what's the appropriate care. Those medical legal concepts remain in place. They will continue to remain in place. But what is occurring as we move into more aggressively into an era of managed care, and as the system evolves structurally, so there are much more organized systems of care as opposed to a more fee-for-service, free market approach under indemnity policies, is what I would call some new standards of accountability, particularly placed on the medical community, where their medical accountability, which has classically been physician to patient in the framework of a medical legal relationship, they're going to have broader views, going to look beyond just that patient. They're also going to be acting in larger organizational settings, whether they be a medical group or an independent practice association, or within a series of health plans, of trying to develop the standards of care and balancing the issues of cost, quality, and access. And these changes in reimbursement, whether it be risk-based reimbursement that's non-capitated, or capitation forms of reimbursement through health plans, are clearly going to change the sensitivity of physicians as individuals, but more importantly, physicians working in organized groups, again, at the medical group level, at the IPA level, of asking very tough questions about the use of technology clinically in specific clinical situations, and the diffusion of technology in a community or where they specifically want to send their patients. And this, I think, is probably the fundamental change that we're going to see happening as we continue to grapple with the technological question, the technological imperative, if you will. I would concur, I mean, to the simple questions of who pays, we all pay. It's built into the insurance premiums. Insurance premiums are built in the cost of goods or services, and we all know that 14% of the gross domestic product. And clearly we have an imperative placed on us by the global we or the specific we, whether it's Blue Cross Blue Shield or Kaiser Permanente or some other payer, or a self-insured employer managing their own medical expenses, the imperative to try to get costs under control. And I'm not certain whether in the 15 or 20 years I've been around health policy, we can ever actually roll healthcare costs back. But I think the goal is to try to get the rate of increase of healthcare costs much more in line with what the rate of increase of costs generally are. If we could ever get to CPI over a 10-year period, I think we would have at least be able to say we've substantially changed some of the underlying cost pressures in American healthcare. And in that regard of trying to get costs under control, I would agree with Dr. Tilford's comment that technology is not all bad. Technology has clearly changed the nature of resource utilization in this city, in the state, and in the country. Procedures are being done on a hospital outpatient basis that previously, 2, 3, 5 years ago, required extensive hospital inpatient resources, lengths of stay, etc. I mean, you can look at the use rates of hospital beds, the number of hospital beds that are in operation compared now to previous years. And when I first met Chad Cheriel, I remember the planning goal of 4 beds per 1,000 for a metropolitan population. And there were real concerns that the way hospital beds were growing, they were going to be extensively more than 4. And now I think our use rates are somewhere down below. I've heard the 3.5 or 2.7 beds, operational beds per 1,000. And those achievements, if you will, compared to say the old standard of 4.0, were achieved in large part because of technology. Because we can do, medical science can do things now on an outpatient basis that previously couldn't, that had to be done on an inpatient basis. And hopefully, in most of those cases, the costs have been reduced. We're clearly changing the length of stay of hospitalizations. If you look at the length of stay for open heart procedures, now compared to 5, 6, 7 years ago, in many cases, in many parts of the country, they've been cut in half. And the case, if you're looking at cost on a case cost basis, clearly in some areas, those costs have been brought under control, and technology is a large part of the reason for that. And I think probably also you can more appropriate utilization of technology by physicians. So technology is, I think, from a payer's point of view, from a consumer's point of view, is in and of itself not evil. It's not bad. It actually helps us move ahead. The problem with technology in healthcare has always been, as Dr. Tilford indicated earlier, a lot of it is additive and not substitutive. And in other areas of the economy, technology oftentimes is more substitutive than additive. And what we have, I think, grappled under in the United States, given the underlying economics of healthcare, is the issue of not really knowing appropriately how to use it. And so it's a much more free market approach, fee-for-service approach, which allowed for technology to both be developed and diffused much more unchecked. I think that the change in underlying reimbursement systems as we move from fee-for-service and indemnity products into managed care, I think we are going to see some dramatic changes in technological development, in the way technologies are introduced, and the way they're used, and the way they're ultimately diffused. And I would agree with some of Chad's comments that I think our vigilance now has to shift from perhaps policing the overuse of technology to policing the quality issue. And I would state, as somebody who's had at least some passing lay experience in utilization review, that it's probably it's much better for health plans to be involved in monitoring quality. It's much more effective for us to monitor quality than it is to try to police and control utilization. And that there are a number of systems that are evolving, including community-based and consumer-based systems like NCQA qualification, which is the National Committee on Quality Assurance, that put in place members' rights, members' grievance processes, physician grievance processes to make sure, and then monitoring of quality to make sure that underutilization doesn't happen. Let me give an anecdote, though, of how I think the changed reimbursement system and really the fundamental changes going on in American healthcare finance are really changing things at the developmental level. There is a major producer of electronic imaging equipment who is now undergoing, they're moving MRIs to what they call MRT, magnetic resonance therapies, where they are actually slowing down the potential introduction of that into the clinical community, slowing it down for at least 3 years, and introducing this new version of technology at select places throughout the U.S., the world, and Portland, I think, is one of the designated places, to begin to develop a better database of the cost effectiveness to go along with the clinical effectiveness, so that physicians that are operating in managed care plans and managed care plans can understand better how that technology should be used clinically and what the cost trade-offs are relative to other technological choices. I would say that at the developmental stage, that's a very sound change to have occur. I don't know whether it will happen in areas of pharmaceutical development and in other areas, but if we can clearly see a new trend that I believe there's an understanding among equipment manufacturers that it's a new market, that it's not the issue of can you sell a piece of equipment on some sort of return on investment to a fee-for-service provider and then be able to get the replication game going. I think the fact that communities of physicians working together either through medical groups that may be in some sort of competitive version or through community IPAs, independent practice associations, I think those medical structures will be the focus around which new debates about how a piece of technology should be used, how it should be diffused, will occur, and I think that's salutary. I think that the debates that occur between a specialty that has a particular both clinical and I would say self-interest, economic self-interest in a new technology needs to, I think, work intellectually and in a scientific basis through the tension of their medical peers within that community, and to be able to get a better understanding of how do we use technology once it's been determined to be safe and efficacious. And I think the overall changes in economics will also change the ultimate diffusion as providers, as groups are balancing the cost issues. I would like to predict that we probably won't see a runaway technology like MRI happen again. There may be some other runaways that are probably less easy to see, but I think the medical community, because of the changed economics, and the hospital community is clearly more sensitized that those are not sound business investments anymore, and they're probably problematic clinically, that we don't need as much of some technologies as perhaps we've had in the old days. I agree with Dr. Tilford's comment on thinking of information systems as technology and that the role they'll play. Clearly, the buzzwords in healthcare, besides managed care and capitation or risk-based reimbursement, are outcome studies. We really know so little compared to what we'll know 5 years, 10 years, 20 years from now as we get better, particularly population-based studies, double-blind studies about the efficacy of one treatment modality versus another, and that information will clearly help us make, I think, more judicious medical decisions and also more judicious economic decisions that will be able to build a stronger consensus between physicians, patients, purchasers, and others. Let me close with a couple of thoughts. One has to do, what's the role of the public sector? As was noted, I've been a member of the Oregon Health Resource Commission since its inception, and there's always been a great debate and I think a healthy tension between what's the role of a public agency or a public commission in looking at issues like technology and the tension that exists between either payers being told what they have to cover by a court or a legislature is one form of that tension. Hospitals being told they can't have a piece of equipment because the CN isn't approved, excuse me, is another form of that tension. I think what we're trying to do in Oregon is clearly incremental. It's clearly trying to frame the debate in a rational way, is to begin to build some information systems and some approaches that we can at least pick out selected technologies that give us pause, the collective us, because of their cost, because of their potential impact on a medical community, and begin to develop the information, both the clinical information and the cost information, and then the processes through which physicians, healthcare demographers, economists, and the public generally can weigh in their perspectives on how should this technology be used, particularly in critical evolutionary periods of something just getting started, and should it be introduced? Should it be introduced under some controlled way? And what responsible role can the medical community build or play and building that community standard, because ultimately it does come back to the community standard of what physicians believe is an appropriate course of action for their patients. I think the Resources Commission plays a role in stimulating that debate and in bringing together all of the stakeholders that are involved in this, particularly the public, to continue to frame the tension that will exist about the cost of technology versus the availability of healthcare generally. We can't look at the technology question outside the larger questions of healthcare. It's also referenced that I'm on the board of Oregon Health Decisions, and I think the issues of values, of what technology plays, the cost of technology versus universal access, those kind of values, I think we've got some opportunities in Oregon to do a better job, to have a more informed debate. And I think generally the medical community and the provider community has been very responsible in engaging in that debate. And I commend the City Club for holding forums like this and keeping the debate going as the system continues to change, it will continue to evolve, and as we learn more about how we can do a better job than what we did 10 years ago or 20 years ago. I look forward to your questions. Thank you.
Thank you. And our final speaker today is Dr. Patrick Dunn.
Thank you very much, Sandy. Given the time, I want to make sure that there's plenty of time for questions at the end, and so I'll try to make my comments as relatively brief as possible. Aside from some of the things that Sandy mentioned that I do, which is kind of teaching responsibilities in general internal medicine in an urban hospital, and then also ethics responsibilities, both within Legacy and also at the university with the Center for Ethics in Healthcare, I practice half-time and talk about changes and the things that the other speakers have talked about so far. The policy decisions that have been made from a social standpoint, the technology advancement, and the payer or reimbursement changes have so remarkably affected my individual practice with patients in the examination room, and the tensions that are there that are different from before. I suspect many of you here may be able to share those similar types of experiences, but they have been very significant. Well, aside from the revolution, really, that has occurred in each of the areas of policy development, technology advancement, and in reimbursement, there always are going to be ethics issues associated with healthcare, regardless of where we sit in each of those three arenas. I'd like to say just three things then with my comments briefly. One is I'd first like to briefly describe the revolution really in the doctor-patient or provider-patient relationship. The second thing is I'd like to describe the change in ethical issues as I've seen them with my practice of ethics in a way over the last 15 years. And then lastly, to end with what might be some future strategies that can be used by each of us in trying to address some of these issues at a micro level. Well, first of all, about the changes in the provider-patient relationship. I really will describe briefly three separate eras. First of all is the era of paternalism, beginning with the father, Hippocrates, way back in designing modern medicine as it is today, that the system previously, though, was an authoritative provider who was giving information, treatments to a patient who essentially asked no questions. In fact, a study was done in 1960 by a fellow named Oken of primary care physicians in the New England area and asked them what percentage of those physicians told their patients they had a terminal cancer diagnosis. And you'd be surprised to know that the result was that only 10% at that time, we're only talking 35 years ago, 35 years ago, only 10% of the physicians would tell their patients that they had a terminal cancer diagnosis. Now let's switch a little bit to the second era. I'll define kind of around that time when things started to change dramatically, to the era of autonomy and the substantial rise in patient autonomy in determining the direction of their own health care. Beginning with Justice Cardozo's decision in the early 1900s about a person has a right to do with what they want with their own body, assuming that they're of sound mind and all. An extension of that then was Dennis Novak at Brown University, who repeated Oken's study from the 1960 study did it in 1975, different physicians, but the same geographic area, and asked the same question. The percentage of primary care physicians who would tell their patients they had a terminal cancer diagnosis in 75 was 90% and not 10%. So over a 15-year period of time, there was really a remarkable shift from a paternalistic model to one that was substantially more autonomous, with patients helping more in their own decision-making. And we saw that with subsequent appellate court case decisions, like the Karen and Quinlan case and the Cruzan cases, for example. And then lastly, I think that we're in another revolution and a switch a little bit away from unbridled patient autonomy to one of social justice. Some would call it social injustice, depending on who it is that you would talk to. But really is, I think, the era of managed care and the control of autonomous patient decision-making because of the constraints of cost and what truly are decisions based on outcome and improved quality. Well, let me move second then to the change and revolution in ethics issues. When I first got into the ethics interests, I guess, it was really in the early 1980s. Most of the problems that we were dealing with newfound ethics committees within hospitals had to do with end-of-life care and life-sustaining treatment issues. It was like the Quinlan or the Cruzan types of cases. And how it is that technology really, the brakes could be put on the technological advances that had been put forward. So from that, though, and from New Jersey court decision, came the suggestion that hospitals develop some type of ethics resource to deal with these issues. And of course, the snowball happened, and so only 4% at the time of President Carter's commission in the early 1980s of hospitals with greater than 200 beds had hospital ethics committees. In 1985, an AHA study indicated that that had risen to 65%, and just a couple of years ago, as we all know, JCHO has now required that all hospitals will have such resources within their walls. But what we didn't realize is that there's been this tremendous environmental change. People are no longer in the hospital. So we've developed this great resource, and we have nobody there necessarily to use it for. That isn't necessarily true. Ethics committees are continuing to do very fine work with the patients that are there. But with the tremendous shift of patients to the outpatient setting, and with the incredible responsibility that's been given to providers to try to help with these, with the patients and the kinds of problems that they're having, we do not have an ethics resource in that setting to try to deal with technological advances, for example, that are causing the increased costs of care and the constraints that that's placing with this changed doctor-patient relationship. Well, the new ethics issues that, again, have been, many of them pushed by technological advances, the solutions to those were described by Mark Siegler from University of Chicago. He's one of my mentors, actually the director of their ethics program there. He suggested that the modern way of dealing with these problems would be, number one, that we would kill the dying, second, that we would dump the poor, and third, that we would coerce the choosers, that is, prevent liberty of decision-making. Well, in the four major areas of ethics issues that I see occurring in the outpatient setting more now are the following, and they're different from what we've seen before. One is kind of the new end-of-life issues. Physician-assisted suicide, Measure 16, good example. A second is resource allocation and relative futility, and both Dr. Tilford as well as Mr. Spade have referred to this issue. That is, how is it that we decide that these new technological advances that may be released at substantial cost, yet have a modest benefit for the patient? How is it that we decide, and who is it that decides that that should be used in specific circumstances? Very good examples. Mickey Mantle. Okay? A second, bone marrow transplantation, I think that Dr. Tilford again referred to for solid tumors like breast cancer. Even kind of milder things that some of you in the room may have personal experience with. New medication called Imitrex. And if you have migraine headaches, this is a new medication that costs between $10 to $12 per pill, depending on which pharmacy you use. Is that worth it to kind of get rid of that bad headache, as opposed to the earlier medications that may not have been quite as effective as that one particular medication. Imitrex already is on the top 10 in expense list for a local payors list of expenses for pharmaceuticals that they have full risk for, just again as an example. But this major issue of relative futility, or that modest benefit for high cost utilization, or high cost for using that particular service, is a major issue. Third is information management, development of an electronic medical record, and the mapping of the human genome. Who is it that's going to have the right to have that kind of information? Who has the need to know that information? And will patients be excluded from plans and not have access because of knowing that they're going to develop Huntington's chorea when they get into their 40s, or breast cancer, they have a 90% chance if they have a positive BRCA gene, for example. And last of the four that I mentioned is the issue of dual commitment that we see really in the more business-oriented environment of medical groups these days. The issues of self-referral. An example might be, we had the idea of a patient coming in with a knee problem that already knows, a very sophisticated consumer market, that they need an MRI. Thinking they need to jump around the primary care physician to not only get the MRI and have the orthopedic referral, they may think that they should be doing the surgery on themselves. I had a patient recently who came in who had a very severe headache problem and was requesting imaging. And it actually turned out that really what he didn't need was imaging. What he needed was an exploration of the meaning behind the request. The patient had a headache, he was under significant stressors, and I think it was really a tension vascular headache. The real problem is that his father had died recently of a brain tumor. So getting toward the solutions, and the last thing that I will just mention is, overall we've had this incredible technological advance that has been one of the things that has driven the increase in healthcare costs. That we have also then had substantial ethical issues that have arisen primarily initially in the inpatient setting, mainly life-sustaining treatment issues, end-of-life care issues, that we have developed inpatient resources to help with. Unfortunately, or fortunately, there's been this shift, as I mentioned, to the outpatient setting, and with the advent of managed care, that we presently do not have adequate resources to try to address these issues at a micro level in that setting. So my feeling is that we, number one, need ongoing advances in sound social policy to develop explicit system for allocation of resources, like the Oregon Health Plan. Second, that decisions about what resources will be used and what services provided allowed by society and covered by society will be outcome-driven, getting to the comments that have been made about outcomes-driven research. And lastly, that the provider groups themselves, along with help from the payers and health systems, need to have ongoing information management to help with utilization review, quality management that we've already heard of, and physicians or providers need help to address the new ethics issues that I've briefly reviewed, and also help with improved and enhanced communication skills in the examination rooms, so that they don't feel pitted against the patient and that there's an adversarial relationship, but the previous fiduciary relationship is maintained. And I will stop my comments with that. Thank you very much.
We're now going to take some questions from the floor. We'll begin with Jonathan Ross, who's on our planning committee. Jonathan?
Oh boy, there's so many things I'd like to ask you folks, and each successive speaker just raised other issues for me, but I'm going to sort of use this as a springboard. Dr. Dunn's comments at the end there. You were making a recommendation that in the future we're going to have, or we're going to need information management, quality management, ethics management. I'm interested in focusing on the ethics management piece. Chad was saying that physicians, in fact, have historically made 80% of the consumption decisions. And then we talked a bit about maybe 50% of the pacemakers put in were maybe not so necessary at all. And I heard this morning on OPB that the American Medical Association, which had taken a position that self-referral was something that you ought to look at pretty strictly, has now backed off that in the age of Gingrich, where now the so-called market system is going to be returned to the healthcare or something. My question is this. Who's going to be the ethical cop in this future where the Office of Health Policy is being merged and sunsetted out of existence, where there's a general hatred of government in any form, where unbridled self-interest doesn't seem historically to have served the public's interest well? Who is it in this future scenario who's going to be watching out for plain old Joe consumer? That's the question I have. And I direct it to anybody who's courageous enough to answer.
I'll start, and that is you'd ask specifically about what it is that we might do with ethics management. And I'm not a macro-oriented person. I'm a micro-oriented person, I think, mainly because of what it is that I do. And so a suggestion that I would have is that primary care provider groups who are being asked by society to essentially be the gatekeepers for the finances that are spent on health care, that they also develop as part of their quality management ethics resources within their groups. They can tap into the already finely developed inpatient resources, although the content areas are different. The processes of evaluation are not necessarily different. So I would suggest that that could be tapped into. Second, that they could develop a resource that would be de novo and not necessarily use the expertise that's been developed in inpatient settings. And I would suggest that those resources would have patient representation so that there's a constituency there, and it's not necessarily an appeal process, but that major decisions that are made by a physician group, where there may particularly be conflict of interest or dual commitment, that there's a sounding board, that there's an accountability, I think, as Barney had put it, to our constituents and our patients. Again, trying to maintain that fiduciary relationship. So a micro answer.
And so that would be, just to make sure I understand, that would be primary care physicians banding together to do the right thing ethically and according to their fiduciary duty, independent of what their pecuniary interests might be. Thanks.
What do you do if you've got one that won't cooperate?
Well, let me perhaps add a macro perspective to what Dr. Dunn just said, because I think that there are at least the beginnings of some processes that will begin to address those questions. And those, quite candidly, those questions existed in the old system, if you will, too. Who's watching out for Joe patient? First of all, the medical legal system is alive and well. So, I mean, the legal system is still there and is still the ultimate court of redress. And I think it makes both the sense of context in which health plans, employers, other purchasers, and provider groups operate. Medical malpractice is alive and well. They're also, though, developing, because of the nature of managed care, all new systems that will help both the purchaser understand how the system that they're purchasing, how the health plan operates, and does it operate effectively. We're spending a whole lot more money than we've ever spent before asking patients in annual consumer satisfaction surveys, can you get into your primary care doctor? Do you like the communication you're having? If not, what don't you like about it? And we take those survey results out. In fact, we have begun a process of intervention with physicians and physician groups that have shown a trend of not meeting patient satisfaction standards that we think are important. I mean, there's a crass commercial aspect of this. If we have unhappy patients in our health plan, they're probably going to go to another health plan. So if we can work with the physician to change that encounter and make it more salutary from both perspectives, hopefully everybody wins out of that. This is relatively new. I'll be the first to admit it, that We've done it 3 or 4 years in a row, and it will continue under because of systems like NCQA qualification. I think that Dr. Dunn's suggestions, and NCQA sets up a whole framework of member grievance, of physician grievance, resolution procedures, and I think in that context, because of the remarkable shift from the hospital as the institutional locus around which a lot of this happens to a health plan, and then ultimately to groups of physicians like medical groups or IPAs, that we will see evolve quite quickly those kinds of committees that are looking not just at utilization questions and classic clinical quality questions, but looking at patient satisfaction and some of the tough ethical decisions about how do we treat these, how do we balance these interests of economics, which is their own economics, against our patient responsibility. Let me stop there.
I'd like to add another perspective. I think I feel very comfortable that groups of clinicians and health plans can make very ethical, legitimate decisions about good resource management to maximize the health of a group of patients. I also believe that there is no way in the world that health plans, physicians, payors can pay for all the technology that could possibly have an incremental beneficial effect for all people. It is not possible. That is when we will consume 100% of our gross national product getting medical care. That's not an economic system that's sustainable. Physicians and health plans cannot make those final ethical decisions about when do you stop offering those incremental little tiny gains, and that's where public policy has to come out and offer some help, because health plans and individual doctors cannot make those decisions.
Just to add 2 cents worth here. In most situations when we have real tough issues of resource allocation, ethics, and so forth, I see 3 possible arenas. One is market-based, which, as I indicated, in healthcare it may be tough, but there are opportunities for purchasers along with consumers to play a much greater role with the plans and providers to resolve some of these potential problems. The second one is clearly the legal one that Barney mentioned, and third solution is really the political one, which may take us into a lengthy discussion, but there is that option.
Thank you very much.
Are there any more questions? Leslie?
I'm interested about the information technology, the communications technology we're talking about. I had the experience recently of realizing that I can get a document to New York faster than I can get a test result across the Willamette River from one testing facility to a physician. And so it seems to me that that's not a matter of technology in terms of is the literal technology available. It's a systems issue that requires cooperation among entities, and like the idea of electronic patient files and being able to transfer those around. I mean, that seems like it's required tremendous cooperation and willing to adhere to common standards. And that's a wonderful vision, but how far are we from that? It seems a big gap at this moment.
I'll start, and then how far we're clearly farther along today than we were 5 years ago, but we have an incredible distance to go. And it starts with a term or a concept you used, which is standards. The reason we have universal automated teller machines throughout the world is that basically the international banking community adopted universal communication standards for something as simple as our bank card, so we can get money out of a checking account in Paris where the account's in Portland. You can actually get your balance at that time. You're right. We've got a long way to go in healthcare. The healthcare transactions are incredibly more complex than banking transactions, but we are moving toward a much more standardized approach of standardizing the definitions of basic encounter data, and we have a nomenclature, and we have national committees that have been at work for at least 3 or 4 years, moving us much farther along on the standardization and the definition issue.
Who's we
The other,
in this case?
pardon me?
Who's we in this case?
American Hospital Association, American Medical Association, the Healthcare Financing Association of the federal government, most of the major third-party payers. It's all in our interest to move to electronics, whether it be for the financial information or clinical information. The other aspect of the issue, besides kind of setting a standardized policy basis from which is going to be the incredible infrastructure investment that this is going to take. If you think of the period from 1950 to 1985 as the explosion of what I call bricks and mortar equipment in American healthcare, I'd like to think of the 1990 from probably till about 2010, 2015. There will be incredible infrastructure investment in information systems. Some of it will not be very smart, and there's going to be incredible interfaces that have to be built between third-party payers, a number of providers, et cetera, and then ultimately a national system. So it's going to be no small cost, but the savings are incredible in many ways. One, you just heard about outcomes research and being able to know more about what to do, but also to, we're also living in a continuous quality improvement world that's being used in other industries. Probably if any of you are in banking or are high tech, you know all about CQI. We're just beginning to apply that kind of thought process to healthcare. And if we can eliminate the redundancies of the multiple lab tests that get done because the information flow is so antiquated, that kind of thing, we can eliminate. That's where technology, I think, can actually save us money over the long haul.
Great. One more quick question.
I'd like to follow up on the point about quality improvement, because my concern is that probably in history most of our advances have come from somebody that was a little bit different from the norm standing up and saying, I've got this idea, and everyone else says you're crazy, and he says, no, I'm really going to, I think this will work, and they follow up on it, and it works, and pretty soon everybody's using it. In these systems you're talking about groups of physicians making decisions for what the norm will be, and that's the only check on the profit motive of these managed care companies. How is that voice going to get heard? It seems like there'll be a tremendous impetus towards conformity and majority rule and getting the meetings over with rather than listening to somebody who's got the new idea. How are these advances going to occur in that kind of environment?
Actually, I think one of the aspects that we're seeing within Permanente, and I'm sure across most medical groups, is we're becoming data-driven, and that is our performance is being looked at continuously across multiple parameters, whether that be how are you doing with satisfying your patient with your interaction with them in the office versus what percentage of your infants are fully immunized at age 2. I think everybody agrees we can do better on everything. The standard of care is not meant to be this is the best we can do. Best practices are very important to establish for this is the best way we know how to get the best outcome now. I think every health system, every medical group is continuously at this point going through a quality improvement cycle of saying this is where we are, we want to bring everybody up to this level, and then let's make the next step up, and let's go from there. Some of the things you're talking about are some of those big jumps that happen when somebody has a really whole new way of doing something that will give you a whole new outcome. But you got to show that you got the outcome, and you got to measure it, you got to get there. So I don't feel frustrated about that at all.
I think there will probably be a whole new process of accountability that documents, that's going to be required to document it, because the opposite of the good idea that makes a quantum leap forward, there are 1,000 bad ideas that have been costly in American healthcare that have led nowhere, that have been, it's not until it's been untested that it's been tested to be a wasteful practice. And so I think what we're trying to do is really get to, I would say, balancing a scientific approach with a new set of accountabilities. And what that means is we're going to look for more information. I think physicians should rightfully look for more information before they just walk in and apply the new drug or the new process. And again, in
clearly, I'm defending an approach, and I'll admit it, that I believe what's happening is that there's more organization brought to healthcare today than ever before, and within those organizational structures, there are going to have to be processes through which this happens. But the organizations themselves, I think, generally speaking, in Oregon, and I know there are aberrations elsewhere in the country, are driven by the motives and the values that Dr. Tilford and Dr. Dunn are looking for. And I think the marketplace will accentuate those values. Quality, access, patient satisfaction. It's not going to be without debate. It's not going to be without tension. But we've had debate and tension in American healthcare for 50 years. It's just we're looking at it from a different perspective.
I'd like to thank everyone for coming. The third of our series will be held on November 16th, and it'll be some of the topics that Dr. Dunn already touched on, the ethical impacts of new technology and standards of care. And that'll be at noon in the same place. If you have any questions about City Club, about the Healthcare Issues Committee or the Technological Issues Committee, please see Jonathan Ross, Sue Ellen, Dahlberg, or myself. Thank you very much for coming, and have a good day.